just to interject a little bit of new blood and get some different ideas. And I think everybody will find this to be a very interesting session. So with that, we're going to start out with Ernie Braxton from Vail. And Ernie, thank you for doing this.
I'm happy to participate, Rick. Okay, so I'd like to thank the hosts of this meeting, the Seattle Science Foundation, and we are going to run through some triumphs and defeats. So a triumph, the first case I'm going to show you is going to be a triumph. It's something that worked out a little bit better than I thought it was going to work out. It's a 74-year-old guy from Western Colorado, presents with myeloradiculopathy following a 2-level ACDF in 2019. He has difficulty with tandem gait, hand intrinsic weakness. And actually, I did the index operation, a 2-level fusion in 2019. I was doing a lot of arthroplasty back then, but I wasn't really doing it in the kind of more elderly population. It's pretty shy about that, and I've gotten a little bit more aggressive. This is how he presented. That's a 2-level fusion that I did. You can see he's breaking down at the level above at C3-4, the anterior osteophyte complex. He's kind of has that he has pain that kind of ranges from a 6 out of 10 to 10 out of 10 on exam. My team ordered an MRI. You can see he's pretty tight at C3-4. He also has some adjacent segment breakdown at C6-7. And like I said, I did the index operation and the guy was actually kind of lost to follow. He's the kind of farmer guy or rancher that will come in for the first follow-up. You know, so I'll see in 2 months, and he disappeared. He showed up about 4 years later with this picture. So I always get CAT scans on these folks, and one, I want to make sure that the fusion construct is solid, but I'm really looking at the facet joints. And I was pretty pleasantly surprised to see that his facets, although they have some mild to moderate degeneration, it really wasn't that bad. So I thought about a number of surgical things that we could do for this guy, and we could just make his ACDF a little bit longer, and that's not without its own risks in an elderly person to kind of do a big dissection like that with a plate. You're going to kind of limit him with more mobility, and the reason why he's here, although he got nice relief from his index operation, he's here because he's developing adjacent segment disease. So is there a way that we could maybe hopefully slow that down? And this is an off-label use of arthroplasty, and we talked about a bunch of different options, but we elected just to go in and put artificial discs above and below. It wasn't that much of a problem to get the anterior osteophytes off. I was able to mobilize the segment pretty well, and did this, obviously through a single incision. We used the same incision as before, just an overnight stay. And then when he followed up, just a total relief of pain, some dysesthesias in his hands, which isn't uncommon for a myelopathic patient to see, but he's just really happy. And his only question was, why didn't you do this at the index operation? So with that, it was an off-label use. I'd like to take a few minutes for Q&A, and then I'll move on to my defeat, a case that did not go as well as I thought it was going to.
Ernie, let me ask a question.
Yes, sir.
Did you give him any prophylaxis for heterotopic ossification? He did have a bone spur at that 3-4 level.
So, well, the index operation. Oh yeah. So the index operation, obviously, no. And then
I didn't mean for that. I meant for the arthroplasty.
So what I did is, after I took off the bone spur, and I'm not sure if this really works, I used a lot of bone wax any bleeding bone edges, and I gave them Celebrex for post-operative pain, but I only tell them to take it while they're symptomatic from pain after surgery. So they only take the Celebrex for a few weeks, and maybe something to consider extending that for a longer period of time. I take maybe this is a cynical attitude, but in a 74-year-old person who's doing well, even if he does form HO and maybe he does end up getting stage 4 HO at that level and fusing it, I really don't think he's going to be that ill-served. That's going to be his biology. And rather than putting him a lot of NSAIDs for an extended period of time, I'd rather not take that risk. And if his biology tells me he wants to fuse that segment, I'll write Medicare and ask for an additional 30% payment on that case. That's a
Ernie, somebody in the chat room asked whether or not you would do this if a patient had OPLL. I know what the answer is, but I want to hear
Oh,
yours.
no, not with OPLL. I wouldn't attempt this type of. Now there's two different types of like phenotypes for OPLL. I mean, if it's true OPLL where they're fused from end plate to end plate, that type of thing, that is going to be an a posterior case in my hands. Maybe a laminoplasty or a laminectomy with fusion with OPLL. But sometimes you'll see just an isolated spot where the ligament is ossified, or maybe it's a disc and it's ossified on CT scan. And I might try to work with them and do that anteriorly if it's just a little spot, even though technically it's OPLL, but it's not like that sheets of bone from end plate to end plate. Those are, in my hands, going to be a posterior approach.
Ernie, what was the compressive pathology? Was it soft? Was it hard stuff? Was it a combination? You use
at C3-4, it was actually soft. There was a soft disc herniation at C3-4, but at 6-7, it really was kind of more firm. It's more ligament and maybe disc ossified complex. But he had a soft disc at 3-4, and I think that level just broke down and he herniated. That was probably the most symptomatic level for him. That's why he came in myelopathic. There's even a little bit of signal change in the cord at that level.
Where?
The signal change, I'll see if you can see my little pointer finger. It's right there. It might be more apparent if I run the video.
So I guess my question is, the guy's happy because he has no pain. He still has his hand symptoms. Was the operation really more for his pain, or because I mean, if you look at it, the cord compression isn't like amazingly huge.
No,
But
I mean,
obviously we treat patients and the patients have pain, and if the pain's gone, they're happy. Do you think this was more for pain or myelopathy? And
so my indication, I mean, I kind of pitched this guy pretty quickly through. I think is more from my standpoint as myelopathy. I was concerned about the myelopathic findings. I didn't elucidate everything, but he 3+ reflexes, Hoffman sign, and difficulty with gait. From the pain,
you didn't mention whether his gait got better. You said his pain went to 0.
Oh yeah. Gait was much better. Just some dysesthesias in his hands, in follow up.
And Ernie, I've seen that often as well. Sometimes these myelopathy patients, they'll get improvement in everything, but they may still have a little bit of paresthesia in the hands.
Yeah.
And it's usually the last thing that I've seen that gets better, but
right.
In those that don't get complete relief.
Right. He was really pleased with his surgical result in terms of balance, coordination, and certainly pain. I mean, pain was. This is the kind of guy that, I told him I need to see him in 2 months for more x-rays and to continue to follow him. And the nice thing about this disc, it's a ceramic disc. So if I need to get an MRI to evaluate the decompression, it shouldn't be a problem. But I suspect this guy will not come into my office unless he's got a lot of pain. He's a rancher in Western Colorado. He just shows up when he thinks he wants something done.
Jens, are you on?
Yes, I am.
Jens, Scott wants you to explain the snake eyes for everybody.
It's the first time I've heard that, snake eyes.
No, I've heard that before.
Yeah.
Ernie, great case. If I saw the video right, I just wanted to show it to everybody. The axials on your MRI scan showed very nice cord signal changes in the corticospinal tract. So if we run through that,
you can also see the snake eyes in ALS, but this is spondylitic.
No, we used to call that a pig snout. When did it
Right, right there.
Yeah,
Pig snout, snake eyes. Many different synonyms for it. But I think it was in the beginning, Ernie, you could see the snake eyes or the pig snout.
You can start to get
back a little bit more.
Right there.
Yeah, right there.
So this guy was myelopathic. I wouldn't be surprised if he had the disc herniation and even waited a period of time before presenting to me. Because like you said, Dr. Blumenthal, I mean,
So
yes,
branching in
we've
the
seen worse
cord.
MRIs, but clinically he
I
was
thought when you, but I,
suffered.
Hey, Ernie, how old was
Yep.
he? He was 72?
now Ernie, my question to you is,
Rick first, he was 74. Jens?
Okay. So I just want to say that, this is a great case. Number one, you can see how we've expanded our indications. If we went by the original FDA, and I get this question all the time from peer to peer. Oh, well, the patient's outside of the original indication. I said the indications were made, 15 years ago. I said we've been doing this for so long. But this is a great case. 74 years old. You saved him a 2-level fusion. Easier on him to have the 2-level disc replacement. And you did a beautiful job. But I
No,
want
I
to
think, I
ask
mean,
you.
honestly, I think that, I mean, indication wise and pathology wise, absolutely spot on. I'm amazed you did it through one incision. I would have done 2 incisions,
Well,
but
that's what I wanted to ask you about. How'd you do it through one incision?
So this is something I've been doing more recently on these cases. Is one little trick that I find is super easy to do and it makes the surgery so much more pleasant is nasotracheal intubation. So talk to your anesthesiologist beforehand and say, hey, do you mind if we just do a nasotracheal intubation instead of standard through the mouth? And that what that does is it gives you about 3 or 4 centimeters on the chin to retract. And then I just kind of I just take this the same incision. I start on him. I usually go after the rostral most level first. I guess my thinking is if I do the caudal level, which isn't as bad, and then it kind of pushes things up, it's going to be harder to get to C3-4. It was not a problem to get to C3-4. I took off the plate first. And did C3-4, and then you just kind of slide down. I just kind of slide down through the same incision, and muscle relaxation really helps, making it a little bit longer. This is honest. I mean, the guy came back and he thought I did a nice plastic, neck plasty job because he had fewer wrinkles because it was just kind of sliding up and down. I think that I like just using one incision and just making it a little bit longer, extending it and working my way up and down. I think the nasotracheal intubation makes it easier to get to the more rostral levels. You could certainly do 2 incisions, but I've just not been as happy with the cosmetic look of 2 incisions. And I kind of think you put a little bit more stretch in the superior laryngeal nerve when you make that really high incision. So it keeps me out of trouble.
I know all my 74-year-olds are concerned with the cosmetic look.
No, but maybe that's more for me. It's more, this is Vail. This is not Central Texas.
Ouch.
Hey, Ernie, we have 1 more minute.
Whoa. Okay.
There were a couple questions. One question said, don't you still use a bite block because you're monitoring motors? And the other was asking about your monitoring.
Yes, so I did monitor use motors on him. I typically do not use motors on my arthroplasty cases. I usually just monitor SSCP and free running EMG if I think they need monitoring at all. In the ASC, oftentimes we don't use monitoring. Yes, we use bite blocks. I kind of asked them this is just kind of real life, very practical thing, is actually a very nice bite block that's not super bulky. It's just a tampon. We just take a feminine tampon and put it back there as our bite block. So it doesn't really, it protects her tongue a little bit better. It's really slick. You can see in there, and every hospital has them.
Okay, but you didn't tell me you put a tampon in his mouth after surgery, did you?
No, I did not. It was a new one, but no, I did not.
All right, Ernie, that was.
Can I just make a
And
point?
every men's room in Colorado has them too.
Yeah.
He has a guidance document that reinforces the fact that off-label use is not illegal, and it's always in the purview of the doctor to use a device in the way that it best serves that particular patient. And I think he did a good demonstration of that, because as the guy said before, extending this to a 4-level fusion, whether you have to do it, just front or front back, would have subjected this guy to a lot more surgery, a tougher rehabilitation, and a much stiffer neck. So very good.
I think, yeah, I agree. I think totally the right operation in this situation. Absolutely.
And I'm not faulting the index surgeon, because that was me. And I saw him when he was in his 60s, and I recommended, a 2-level fusion because I was trying to stay more within, the indicated cases. But as my practice has matured, I've gotten more comfortable. And the literature shows this, in my own personal data experience shows that I see less adjacent segment disease when I'm preserving motion. And so rather than, kind of like repeat the sin again, I decided to the next time around to do an arthroplasty instead of a fusion.
Well,
Ernie,
the literature,
that was a great
totally
case.
supports you as well.
Yeah, timekeeper, we got to go to the next case.
Sure.
That was a great case, lots of lessons. Now let's
Okay.
hear the bad one.
Okay. So this is a case that didn't work out as well as I'd like. This is a 57-year-old woman and who presented with right-sided neck and arm pain. She got diagnostic relief from a transforaminal injection at C5/6. She failed to respond to 3 months of physical therapy, and she had a history of a 6/7 TDR that was done 40 years ago. And I was the index surgeon for this. These are my own cases. I didn't really know what a farrier was until I met her, but she's a woman that shoes horses, and so she's constantly bending her neck forward. And she says that she has so much pain that she can't work as a farrier, which is what she really loves to do. This is how she presented. Her neck disability index was about 66, and her pain really limited her from doing anything recreationally at all, and made it really difficult for her just to work, and affected her sleep as well. So I did this case in 2019. I used an unconstrained device on her. She actually did very well for the first few years. And then slowly she started developing some neck pain. I sent her to physiatry. And then I started noticing this, where her implant was kind of getting more and more kyphotic and being locked in kyphosis, even with flexion extension x-rays. This device is made of cobalt chrome and polyethylene. We got a Mars protocol. This is what Mars protocol looks like at our facility. There's a fair amount of artifact and shadow at 6/7. I thought, interestingly, she does have like an osteophyte complex and some narrowing at C5/6, but that's mostly on the left side. I'll show you on the sagittal. She's got this kind of osteophyte complex on the left. But I thought 5/6 was kind of starting to break down. I couldn't really get a great view at 6/7. Considered getting a myelogram, but I mean, at this point, I just decided to get a CT scan just to take a look and see, how do her facets look. She has some facet disease at C3/4, but I thought 5/6 was pretty good, and I thought 6/7 was still pretty good. I don't really find these 3D things all that useful. They got one for me. You can see that it's kind of locked in kyphosis. And although I didn't show the FNEs on her, the disc didn't move anymore, as opposed to how it started in the first few years. So, I kind of ran through a couple concepts with her. We could, try additional injections and conservative care, but she was just continuing to get worse. And I kind of had done that for about 3 months already. I don't do cervical spinal cord stimulators, but I could send her out for a spinal cord stimulator trial to see if that would help her symptoms. She doesn't have a lot of motor weakness, and it's mainly pain. We could try revising this posteriorly, maybe a posterior fusion or foraminotomy, or revision anteriorly. And usually when I have a disc that looks like that, I usually convert it to a fusion. This is a lady that kind of sought me out for an artificial disc on her index operation, was really happy with it for the first few years, and was really opposed to having that converted to a fusion. I also wanted to include the level at C5/6 because there was some degeneration there, and that's where the injection was, and that's where she got a lot of relief from C5/6. So I was a little bit confused. So that was kind of my failure, and it's a failure of the implant. Perhaps on my implant selection, perhaps on end plate preparation. Anyway, she talked me into doing a disc-to-disc revision, and she's actually ended up being really happy with it. I kind of upsized that disc, put a little bit larger footprint in there, drill up more of the uncinate process to kind of get in there and do a nice foraminotomy, removing the majority of the uncinate process to free up the nerves. And I also put in a smaller disc at C5/6. Was able to preserve her motion on FNEs, and then her NDI went from a 66 to about a 22. back to work, back to recreational activities. She still complains of some soreness at the end of the day, which she says is about a 2 out of 10. And so that was a failure of an implant. I thought that might be an interesting case to present of doing a disc to disc revision. And
Ernie, how far out is she now?
she is about a year out from that case.
And don't beat yourself up. It's not your fault the disc failed. I mean, this is something that we've learned with the unconstrained devices. I mean, sometimes they look funky, and patients have pain from that.
Oh yeah, I know, but it is. I mean, it is ultimately, a revision, and you got to call a ball a strike and a strike, balls and strikes, and
No, I know, but
that didn't go the way I wanted it to.
yeah, and we all know that the Moby C, being non-constrained, you'll get that funny settling down at the end place, then they'll get locked. And we all started out thinking, oh, this is great, it's easy to do, and but it's a finicky disc. It reminds me of the old Charité. They were hard as all get out to put in right, and it took a lot of practice, and even still we would get some that would look funky, and I think that's the same case with the Moby C. I know that they're doing some redesign work. I don't know if they're going to make it a little stiffer, but I think the next generation will be.
Yeah, I think so too. I saw a question like, did I get a DEXA scan on the index operation? I honestly don't recall getting one. But I know that when I was, first doing a lot of these discs, I'd always get a DEXA scan. I wouldn't operate if it was abnormal. The T-score was even osteopenic, -1. I still do that routinely for all of my lumbars, but I've kind of got backed off a little bit on the cervical, so I do not remember if I got a DEXA scan.
Well,
what did our paper show? We did a paper. What did it show?
Yeah, we did a paper that showed that we only had, I think, 1 or 2% of patients of cervical that we backed off because of the DEXA. And if you think about it, in the cervical spine, it's supporting an 8 or 10-pound head, depending on how big of a head you have, in comparison to the lumbar spine where you're supporting the trunk. So we stopped doing them routinely. And
yeah, someone. I'm sorry.
What?
Go ahead.
No, go ahead.
I was going to say, Rob, so unless someone has really high risk factors for osteoporosis, Rick said it correctly, we've really stopped doing DEXA scans on cervicals. And Ernest, the concept of disc-to-disc revision is really something that we've looked into. We actually took out 3 Mobies today in 2 different patients. 2 of them I had to revise to fusion when I did a disc to disc, and we're up to almost about 60 cases. About half of them are our internal, and half are our cases referred to us for multiple reasons of failed arthroplasties, whether it's osteolysis, whether it's subsidence, whether it's hypermobility, which seems to be very specific to the Mobi, or getting locked into kyphosis. Those 2 are very specific to the Mobi. Of the discs that we've done disc to disc, the Mobis are the most applicable because they preserve the end plate the best. So what that case that you did is we've got a dozen of those that look just like that, and I think that's, for an arthroplasty surgeon like you, I think that's the standard of care in a situation like that, and not to automatically, kind of revert to saying, oh, you need a fusion, your Mobi's locked in kyphosis. I think that's absolutely 2024 revision case. So I'd call that a triumph, not a defeat.
Yeah, and go ahead.
Just a little hat tip to Texas Back. I actually tried to send her to Texas Back for a disc revision when that's what she wanted, because I was kind of more of the ilk of like, let's do disc diffusion, and she kind of really twisted my arms like, I'm not going to Texas, it's too hot. And so she ended up insisting that I do it, and I kind of laid it out. Obviously, I get in there and the end plate, there's not enough end plate, or I feel uncomfortable, or I just think it's not safe, or you're going to get a fusion. And so the first question she asked out of anesthesia is like, did I get a fusion or artificial disc? And she was really pleased to get the artificial disc. And I think patients do better when they get what they want,
No, that was a perfect result. So
That's what
and the reality is, in the best of circumstances, there's a bunch of literature out now, and the incidence of failure to the point of meaning revision is from like 1.5% to like 3.5% in the literature. So, you've got a big arthroplasty practice. You're going to see those, at a low rate, lower than hip and knee replacements. And then the ones that other surgeons that aren't as comfortable as you get referred in, you'll see an increasing amount because cervical arthroplasty is being done, at a huge rate across the U.S. now. So,
Yeah.
I think
She was my first disc to disc. Since then, I've done about 4 more disc to disc cases, but that was my first. She kind of broke my cherry on that. I'm getting more comfortable, and it really involves getting really lateral to the incident process, getting all the way around it, and fighting like a fresh plane.
But here's the one caveat, whether it's relevant or not. When we do these revisions, we culture always for C. acnes, just to be sure. And we found our rate anywhere from like 20 to 30% in non-osteolysis cases to over 50% in osteolysis cases. What to do with that, I don't know, because they're not clinically infected, but that does seem to be something that we see in the cervical revision literature and in the in the scoliosis surgeons who do a lot of revision lumbars. There are 20% positive C. acnes or staph epi cultures as well. I just throw that out there, something, as a learning curve thing. It may be clinically irrelevant, but who knows?
I see how it can help. I did not get the culture, but as you know, C. acnes is very indolent. It's not going to make a game change. You're not going to be able to use that information during surgery. It's going to be a week later or 2 weeks later. And I suppose if it were positive, I'd probably put her on suppressive antibiotics or I get an ID consult if it were positive.
Hey, Jack, you were going to say something?
I was just going to say, we have a low threshold to put them on doxycycline until you get your cultures back, Ernie, and then, take them off it. And I was going to ask Scott, there are some patients that have cultured positive, but I don't think you've ever had to take somebody back for a secondary debridement, right?
No. And we started using ID consults, and they would put these PICC lines in for 6 weeks. And unless it's grossly infected with purulence, which is, less than 5 cases of those 60, we just use 6 weeks of doxy if they culture positive. It's simple as that. And as Jack said, we've not had to take anybody back for infection.
All right.
Well, I think that's 2 triumphs. You owe us a defeat the next time.
Ernie, you got to get the term right. Triumph versus defeat. Both were triumphs.
She wasn't pleased with her, like the fact of going back and, I didn't feel like that great. I didn't feel like a hero in that case. I was trying to salvage something.
No, you were a hero because you converted her to another disc. So you did a great job.
Well,
all right, we're going to move on. Thank you, Ernie. And you can pipe in while Rob gives his cases. Rob, are you ready?
Yeah, let me see if I can get this screen shared for you guys.
You look very nice in your tie, by the way.
Oh, thanks. Let's make sure this is working for us.
Yep.
So there we go. So first of all, thanks for having me. I appreciate it. I'm kind of excited to hear different perspectives and continue to learn how I can improve. And I kind of, if you don't mind, I kind of started with the same slide that Corey sent us, mostly because, to tell you the truth, the triumphs and defeats, I've never actually thought of it that way. I know that may sound a little odd to people, but I just haven't. And so having said that, this next slide I purposefully left as very busy and very chaotic, because these are all cases that I've done over the years, and they all obviously have their own stories to tell and why things were done and what they were done for. But for me, I've always kind of thought of cases and surgery and stuck to the idea that I do my best to kind of preoperatively plan, plan A, B, C, and any contingencies, and as best I can foresee any possible, complications or things that we might come in front of. And then every single case after, it doesn't matter whether it goes smoothly, whether it goes rough. I sit down with my PA and I sit down with my rep and we go through it and we kind of say, okay, what went well? What didn't go well? What did we not anticipate? How can we improve? And so to be honest, I've never really thought of it as triumphs or defeats. And so that was kind of a new way of thinking about it. And maybe I need to think of it more that way. But having said that, I kind of tried to pick some cases that weren't too far off the wall. Like you can see on this slide, I got all kinds of cases I've done over the last 9 years, and all kinds of results. But having said that, I tried to pick some that hopefully I can learn more from you gentlemen as well. And so this first case, obviously I didn't throw in all the pictures, all the diagnostics that take a long, long time. But this is kind of more of a traditional Idahoan. A 58-year-old, he grew up a farmer, farmed most of his life, construction worker. But as most Idahoans, and especially Eastern Idahoans near Yellowstone, you're a hunter. And you literally disappear for a month and a half in the fall, and nobody ever sees you. Your wife's a widow. And so this gentleman came to me. He had also served in the military and been injured way back when, if you will. He came to me with a primary complaint of the back pain. He's had chronic radiculopathy, L5-ish, bilaterally for years and years and years. But the back pain was just getting to the point where, to tell you the truth, he didn't really care about work, and he cared more that he couldn't go hunt. He couldn't haul out and quarter out an elk. And so that's why he came. And the chronic radiculopathy, the radiculopathy is more of a secondary thing for him. For me, I'm very regimented. When I first came out of fellowship, I kind of bounced around a little bit, tried a little different things, and just having taken care of, various types of athletes, from, professional athletes, all kinds of different walks of life. I kind of just got to the point where I stick to my routine so that I can try and get the best results I can every single time. And so I always obtain a CT scan, an MRI, x-rays, flexion extension views, evaluating dynamic and static instability and listhesis and lateral side bending. I still, and maybe this is something I need to change, but I still get DEXA scans. I want to know healing potentials, especially with some of the newer medications out there like Prolia and things like that, that have shown really good success. Occasionally I'll get EMGs depending on what's going on. Like in this individual, I did get EMGs. I want to know, to what degree these nerves are being affected and how long. And then I still try my best to do diagnostic blocks, looking at posterior column mediated pain versus anterior column mediated pain. So point being is, this gentleman had kind of exhausted everything. He went through the medial branch blocks, kind of demonstrated about 20 to 30% pain relief. We tried to do a basivertebral nerve ablation to kind of help isolate some of the anterior column mediated pain and kind of help paint that picture and that patient expectation, if you will. But unfortunately, his insurance denied that. And so he got to the point where he's like, you know what? I'm ready to pull the trigger. I'm ready to move forward. As you can see from the x-rays, he's got listhesis at multiple levels, most of it's static, very little dynamic. He's got osteophytes, degenerative disc disease, disc collapse, multiple levels. But this gentleman was just absolutely adamant that he will not fuse, would not fuse. He didn't care what it cost, what he needed to do. He just absolutely did not want a fusion. And so we did our best to kind of help him understand those expectations and the pros and cons and all that good stuff. And so he chose to kind of go forward with that disc replacement. Once again, with every patient, I kind of follow the exact same algorithm. I don't really change. With this patient, because of the chronic radiculopathy and how many levels were collapsed, I really was a little bit more concerned for that neuropraxia. So I kind of use I have a neuropraxia protocol that I typically use with most patients that I anticipate being, a little more, having a higher propensity for having neuropraxia. And that starts preoperative all the way through postoperative. So we instituted that as well. As you can see here,
Rob, why don't you explain what the neuropraxia protocol is?
So first of all, it kind of boils down to, when I look at a patient, I look at the chronicity of the collapse. I start looking at modic changes. How long have they been bone on bone? How collapsed have they been? How many data points do I have to kind of anticipate and look at that progression, if you will, of it? And then I kind of, a little bit of it's a guess to say, hey, the longer you've been collapsed, the longer you've had chronic radiculopathy, if you've had previous surgeries, scar tissue, et cetera, you're probably at a higher risk for stretching that nerve out. I mean, that's just biomechanics. You go in there and you stretch that nerve out from 0 to, whatever implant you're putting in there. And so typically, if I have a patient that we're seeing that, in my mind has a higher propensity for that, I typically will put them on a very, very aggressive stretching regimen going into surgery and starting as soon as we possibly can. Very aggressive stretching. And then obviously intraoperative, we're doing, as possible, we're doing IV steroids. I also do my best at trying to do bathe the nerve roots. When I do my disc replacements, I release that PLL with my Cobb elevator. And oftentimes, they have, annular tears and things like that. So I try and get that steroid out there near the nerves as well, and then the exiting nerve roots. And then post-operative, we keep them on some IV steroids in the hospital. We begin a stretching regimen in the hospital within reason. It's more of a toned down stretching regimen. And then oftentimes, if they're, like I said, a higher risk, I'll keep them on about a 2-week taper of steroids. And then we transition into an anti-inflammatory after that. And then all of that time, we're instituting kind of a soft or a baby stretching regimen, working those hamstrings, working the glutes, the gastrocs, and trying to keep things loose, if you will, and kind of help stretch those out. So that's kind of the overview of that. That makes sense?
Yep.
So that's typically what I'll do with a patient that just in my mind is going to kind of have that higher risk. And so I did that with this guy, not necessarily because he was super collapsed from top to bottom or he's showing tons of modic changes, but because we're doing 4 levels. And the more levels you do, obviously, the higher the height and the stretch of all the nerves we're encountering. And so in his particular case, it wasn't necessarily because he was bone on bone. It was more because of how many levels we're doing, the chronic radiculopathy, and some of those other aspects in this specific patient.
And Rob, how did you decide that all 4 needed to be done?
This was kind of a discussion between him and I. It was a discussion between the two of us. As we're looking at that MRI, you can obviously see the upper discs at L1-2, T12, L1. Still look fairly good, still fairly hydrated. It's really those lower 4 that are having the most issues. And we had the discussion. We said, hey, we may not be able to get to the L1-2. He's obviously having some issues. You have some anterior osteophytes there. He is starting to collapse. He's still fairly hydrated, if you will, but he's not as bad as the lower 4. And so we literally have the discussion. We're saying, hey, here's a situation. If you did 1, you might still have some back pain. You might still have some of these issues because of the other levels. If you did 2, 3, 4, and so on and so forth. So it's really an open discussion. And that's why with that algorithm, I don't really skip steps. I kind of always stick to my same pattern because it helps me paint a picture for that patient as to what is going on with them. Where is their pain coming from? If we do meter branch blocks and they come back and say, hey, geez, that took 80% of my pain away, we have a very candid discussion as to, okay, well, if you do a disc replacement, you might still have a good chunk of 80% of that pain. Is that really where you want to go? Is that really what you want to do with your body? And so it really boils down to trying to help manage the patient's expectations and give them the option. In my opinion, I do my best to try and say, are they an appropriate candidate for the surgery? But it's their decision. So as you can see, kind of the MRIs, quite a bit of foraminal stenosis, L5-S1, associated with those bone spurs, a little bit of L4-5, not so much as you get up, but most of his symptoms were that L5-S1 region and the foramen. This left-sided picture over here on the upper portion is the left side, and then the right side is also the right leg. And so then he chose to do a 4-level disc replacement. So we did a 4-level disc replacement on him. The upper pictures are obviously the intraoperative films, and then the lower pictures are about 1.5 years out. To tell you the truth, the guy loved it. Unfortunately, it's one of those hard situations where you're shaking your head at the guy because 6 months after surgery, without my permission and without my recommendation, he was quartering an elk with his son and trying to haul it out. That's how diehard these guys are. And so, yeah, that was when I look at this case, I don't necessarily look at a success. I don't necessarily, or triumph. I don't necessarily look at a failure. I look at it as a case and what could I learn from this? He had a little bit of neuropraxia. We actually, on him, we extended our oral steroid a little bit longer. We continued our stretching regimen a little bit longer, kind of kept him on anti-inflammatories for probably a good 3 to 4 months. And with that kind of protocol, it actually calmed down, and he's done great and enjoyed it and loved it. Kind of, unfortunately, he always brings us elk sausage and salami every year, but I'm not going to complain. It's pretty good. So,
Rob, did you do any selective nerve blocks for the 5 roots before to see how much relief he got? Because
yes.
on your sagittals, those foramen were really tight. So my question to you is, I think what I might have done is a right-sided 5-1 and see what you get. So you decompress the 5 roots by indirect decompression of the disc space and elevating it, and you could always come back another day to do the cephalad levels through the left side.
Yeah, so actually I do. I did the EMGs, as we talked about, which actually demonstrated some chronic radiculopathy in that L5 bilaterally. And because of the pain that he had with it, yeah, I did transforaminals bilaterally, actually, both for diagnostic and therapeutic measures as much as they could approve, if you will, or help him out. The other levels we didn't really do because he didn't have that pattern. It didn't fit any of his radicular symptoms. He hadn't had symptoms in any of the L4, L3, L2 regions. So I hadn't really targeted those.
So that's what part 2 of the question. If you had just done 5-1, might you not have made them better, without the other levels? And if you did it through a right-sided approach, you could still get back there if you felt you had to later. I'm just being devil's advocate.
Yeah, and that's a discussion we had with him. I really, to tell you the truth, one of the things that I think has really helped my arthroplasty practice has been the basivertebral nerve ablation, both from a diagnostic and therapeutic measure. I mean, to be honest, you ablate the nerve, you ablate the basivertebral nerve, but the nerve, they're still going to have exacerbations. They're still going to have collapse. From a physical standpoint, biomechanical, they're still going to collapse. But it does, what I found in my practice, help them understand diagnostically how much anterior column mediated pain do they actually have. And so it kind of helps them make that decision. And so optimally, if I had my druthers, my choice, I would have been doing BVNAs at all of those levels to try and help him understand, well, how much pain is coming from these different areas, and potentially even altered them if you could have. But that's just not the case. His insurance wouldn't let him do that.
So Rob, for the attendees, obviously you've got a great access surgeon. Talk about relationship spine surgeon to access surgeon and tell us about, because this is a big case.
Yeah, so pivotal. Absolutely pivotal. When I first came out, and as Dr. Geyer had mentioned, I trained at Texas Back Institute, and Dr. Lieberman kind of had us always do our own exposures. And so I came out of fellowship completely expecting to do my own exposures, 100%. I got to the region and found that a lot of the other surgeons, who none of them were doing disc replacements, they were all doing A-lifts, but they had a few different access surgeons who helped them do that. And I kind of, said, oh, well, this is kind of the standard of the care here in this market. I probably should follow suit. And so I started kind of working with a few different ones, found one that I had complete faith in. And since that time, we have worked together to, expand not just, his previous 1 level, 2 levels max, to being able to do really whatever we want. We've even contemplated, I hate to say it, and I'll take the criticism, contemplated L1-2s where we're looking at chest x-rays, CT scans, MRIs, where's the diaphragm, where's the arteries, what's our approach angle, do we have a xiphoid in the way, etc. We've really been able to do quite a bit of different cases, but it's been a learning process for both of us. He went back and trained how to do access many, many years ago, but he'd never dived into it as much as we have. As you saw from kind of that complicated chaos slide, as I put it, we've done quite a few cases where we're going back in revision after revision, et cetera, where we've had, all kinds of situations. And so I think it is something where if you're able to find that partner, because he really is a partner, who you're comfortable with and confident with, in diving into some of this stuff, it definitely makes it easier, less stressful. I mean, trying to do this all on my own would have been just absolutely a nightmare of stress. And so I think if you have that ability, it's absolutely pertinent.
Hey, Rob, listen, we're running out of time for this case. That was a great case. But several of the participants asked the question, how did you get this approved by insurance? I know the answer. You didn't get insurance approved, but how did you do it?
So this gentleman, I believe he actually did get it approved through insurance, but I believe it was either VA or something of that nature, if I recall right. I can't recall, to tell you the truth, but his was covered from some entity, and I can more than happy to follow up with that in the long
No,
run.
and it was just a question. Listen, we have to move on, so we'll come back and Ernie, if you hold your question, we'll
That was
hopefully
my
have
question. Like, you couldn't get an intercept approved, but you got a 4-level arthroplasty approved. It just seems a little.
Tell me about it. Tell me about it. So,
All right, Rob,
all right,
let's see the next.
yeah, this next case is once again kind of a I don't think of it as a failure, but super nice gentleman, 63-year-old male, retired, lives on a nice, beautiful island, but super active, retired young, wants to keep running, wants to keep active. Same thing, kind of chronic back pain, intermittent radiculopathy, but his primary complaint is chronic back pain and wanting to be able to continue to be active. So same kind of regimen, went through everything. He didn't want to do the BVNA, so we obviously didn't make him. When we're looking at the x-rays, that L5S1 really stands out on the x-rays. As we look at the MRIs, he starts to have that disc bulge, broad-based disc bulge, causing some lateral recess stenosis at 4-5, which upon looking at all the imaging really was the component of that intermittent radicular symptoms. And so we had that open discussion. We said, you know, hey, are we addressing both? Do we do partial discectomy, do foraminotomies? Do we do this all from the front? Now, I've done this many, many times in my practice. If I see a disc, such as that upper right corner where it's contiguous with the disc space, more often than not, I can get it straight from the front. And then you have that indirect decompression aspect of it as well. And so going through the same process, don't skip steps, he chose to do a 2-level disc replacement. So we did 2-level disc replacement. There's intra-op, no issues intra-op, no complications. I still use that neuropraxia protocol because of that L5S1 level. 4 months later, he started kind of complaining of just some abdominal pain and having a belly, as he put it. He said, I just have a belly. He's like, I never had a belly before. What, do I have a hernia? Do I have what? A little bit of nausea and abdominal discomfort. Nothing crazy. And so a rhetorical question, kind of thoughts. And, you know, this was probably later in my practice, probably 5 years in, that I had this happen. And so we started investigating it, did a CT scan, started looking at MRI, huge fluid collection. So everything's going through your mind, right? Everything, hematomas, infections, you know, bladder injuries, ureter injuries, all this kind of stuff. Once we kind of dived into it, we're like, well, what do we do now? What do we do with this guy? He doesn't sound sick. He has no white count. He has no inflammatory markers. It doesn't appear to be infectious. Etc. So we boiled down to saying, okay, what do we do with it and how do we go about taking care of this? So we did CT guided aspiration, sucked it out, tested it, sent it off for culture, all that good stuff. Aseptic, no infection, comes back lymph, and a pretty big lymphocyte sitting there, pretty darn big, to the point where the guy says, I have a belly and I'm pregnant and I never did before. And so we're like, okay, well, we did compress it. We did a percutaneous CT guided aspiration. Well, 4 weeks later, comes right back. So we're like, well, geez, what do we do now? It's coming right back. The CT guided isn't working. And so between discussion with me and my access surgeon, we kind of talked about it. We researched as much as we possibly could to say, what do we do with this? How do we go about addressing this? And we kind of decided that the next steps for this guy was to do an endoscopic peritoneal window. So we went in and I jumped in. I assisted him this time on the surgery, and we just did a peritoneal window. And it worked fantastic. No reaccumulation, no residual discomfort, no pain, no weakness, nothing. He's happy as a clam. And this is a year post-op, and now he's running all he wants. I think he just did a half marathon just this last month. He sent me some pictures, and so this is one of those learning moments for me where, I guess I would consider that a defeat to some extent, where I had to learn. I did not anticipate that, and neither did my approach surgeon. So.
And Rob, how many months later was it that he complained about his belly after surgery?
So it took about 4 months. He had started noticing, kind of, as he put it, he just felt bloated. He just felt like his belly was getting bigger. And then he started getting a little more pain associated with it, abdominal pain and nausea. And he was back on his island. And so unfortunately, on his island, they did not have access surgeons who were familiar with this. They didn't have the CT or the IR individuals that were as proficient with it. And I talked with them directly, and they're like, well, we've never seen this. We're not sure what to do with it. And so he had been back on his island. And so he actually flew in for us to take care of him. So it was probably going on, developing for quite a while. And just because of where he was at, we didn't necessarily pick up on it as quick.
I just want to query Jack and Scott. I had one, and we just left the drain in event, but we discovered it, shortly after surgery. So I just put a drain in, and then eventually it stopped. And I think somebody else had one that might have lasted a little bit longer, but again stopped with a drain. Scott or Jack, do you remember any patients with a lymph?
It's Todd Landman's on it. I think Todd had some personal experience with this also, but I was going to ask Rob, the peritoneal window, I mean, you just want this to drain intraperitoneally so that it gets absorbed.
Exactly.
Peritoneum. How do you keep that? How do you keep the rent in the peritoneum open so that it keeps draining?
So it boils down to size. So kind of touching back on what Dr. Geyer said, I actually did have another patient where we did a drain, and unfortunately it just kept draining and it kept reaccumulating. You pull the drain out and then it come back. And so we ended up doing a window in him as well. But you do a pretty large window. Like, this isn't just a tiny little rent. Sometimes with your access surgeons, they'll say, oh, that rent's, not that big. I'm not going to sew it up. I'm not going to worry about it. And so we're literally cutting out a box so that it just drains right in there, and then it absorbs, and it's actually pretty seamless. So, I mean, it's a pretty good size. We're talking probably 3 to 4 centimeters by 3 to 4 centimeters.
Rob, did you have him change his diet at all to a low-fat or zero-fat diet? Because that sometimes can be helpful.
I'll be honest. We tried a lot of things. We went through Lasix. We went through just getting him dry, changing his diet. We went through a lot of different things with not just this guy, but we've had a handful of these over the last 8-9 years. And we've tried that. We tried drying them up. We tried all kinds of things, and it definitely has shown that it helps slow, at least for me in my experience, it helps slow the progression of it. But we were never able to get it to stop. Even with leaving the drains in and taking them out, it would still slowly come back. So this is the one thing that, at least for us in our practice, my practice, that I found that, does the job.
It's like analogous to getting a tear in the neck, of course, walking on it, where you can get lymphatic leakage. And if you can't track it down, it can be a symptomatic problem later for the patient. So in the retroperitoneum, every once in a while, you'll see a drop or two of lymph. And I know my access surgeon was always really careful about trying to find it and cauterize the end of it. But we've never had to deal with a basketball this size. But I know it does happen, and I think Todd Lamon, as I said, had some personal experience with it.
Yeah, when I saw the CT, it looked like, and we've had them before, a urinoma, when you like nick the bladder or ureter.
Yeah.
Yeah, in fact, I had a case like this where it turned out to be a urinoma, and the patient, again, was from out of town. I finally said, you need to come in. Well, it turned out that there was a partial tear in the ureter, and the IR, and he had a big belly. Our access surgeon did not want to go back in. So the urologist went retrograde up the ureter, and the IR guy dropped the catheter through the kidney down, and they pulled it. I guess he pulled the catheter up from below. And knock on wood, that saved him a huge operation, me a lot of aggravation, and he went on and he healed just fine. But that's the other thing. When I first saw that, I thought, oh God, that's a big urinoma.
Yep, crossed my mind.
Hey, Rob, I just want to talk about your neuropraxia protocol because we'd written a paper about the active L, post-op neuropraxias, and it's about 10%. And we found that, what doesn't work is to do surgery, but, you can put them on steroids, you can put them on Neurontin or Lyric or whatever. What I personally have started doing is to pre-treating them with the Neurontin immediately after surgery, and we'll hit them pretty hard with about 2 to 3 doses per day. And I found that it modulates it much less. We still find it to occur in about 10% of our patients. But what happened in the past, the patients would come back in 2 weeks and they say, oh, I was doing great till a week ago and I have this terrible leg pain. By that time, you've already lost it. So by pre-treating them, and like what you do with the pre-stretching, I think if you treat them preemptively, then it becomes much less of a problem.
I would agree. Absolutely. At least that's what I found. I mean, I kind of bounced around for the first few years trying to figure this out and looking at it, but this is just, it's what I found over the last 5 years, and hopefully we'll be able to publish some data here in the next year or so on the last 5 years of Active L, Pro Disc L, et cetera, and kind of how that has turned out. Because I've kind of stuck to the last 5 years. It just seems to work for me.
Yeah, no, glad to hear that. Because the only time we looked at this scientifically was very early. It was like at the end of the IDE studies, and we were unable to find a prognostic factor that influenced patients to whether they're going to get a neuropraxia pain post-op or not. We looked at things like the amount of disc space collapse, prior surgeries, things like that, and there was just no correlation. But that study is 20 years old now, and again, it just involved the IDE patients. It would be nice to do that again now on real world patients and find out whether we missed the boat, whether there are prognostic indicators so that we can pre-treat the right population and not over-treat everybody. So I'm glad you're getting it together.
Yeah, I mean, the good news is that both Lyric and Neurontin are generic, so it's not an expensive treatment for 2 weeks, prophylactically. But and as Jack said that, there was really no correlation. We thought that the very collapsed disc would be the ones that would get it, but not so. I mean, sometimes the discs that just mildly collapsed would be the patient that get it. It's still an entity that we haven't well defined. Ernie,
Are you
do you
still
have any?
pacing the nerve with a stimulator sometimes, like with the spinal cord stimulator? I remember you mentioning that as being a possibility.
Yes, when Ralph Rashbaum was practicing, occasionally if a patient had a rip-roaring radiculopathy, he would put a temporary spinal cord stimulator in. The only problem is it's a really expensive treatment. I don't know what they would cost the insurance company, but he talked about pacing the nerve with the stimulator, and then he would take them out. So, but it's something that we see all the time, and unfortunately, we don't have a good answer as to why it occurs.
Well, great
Are
case.
there any more?
Good
Go ahead.
Nice to get new blood.
Yes, these were great cases from both of you, and you've taught us, at least me, a lot of new things. Ernie, I never thought you could get to 4 levels with the single incision, but I'm going to have to try that. And Rob,
Don't forget the feminine hygiene product, the tampon for the body.
yeah.
Lexicon keeps things out of the way. It works great.
I have a female anesthesiologist. Do you think she'll get upset if I say, "Do you have a tampon in your purse to put in his mouth?"
Yeah,
It's
she
sterile,
will.
guys. It's fine.
All right. Well, listen, we thank you a lot, both of you. We're going to have you back. And for everybody online, don't forget to claim your credits. The number is 1184. So again, thank you, Ernie, and thank you, Rob. And we really appreciate it. Great cases, great lessons. We all learned a lot, and it was a lot of fun having you.
No, I'm glad you had lumbar and I had cervical. I couldn't decide what to do, and it kind of worked out.
No, it's fine. These were all great cases.
Yeah, we coordinated, we planned. Good.
No,
Thanks a lot.
great job.
See you guys.
All right, take care and have a good
Guys.
evening.
All-star
And
game.
Sergio, I'll have to see if we can get subtitles in English for you, but I'm going to let that up to Corey.
See ya.